On behalf of the American Heart Association, I would like to welcome you to today's webinar, The 4 F's of Anticoagulation Risk Assessments, Forgetfulness. My name is Anmol Dalwadi, and I am a Quality Programs Manager for the American Heart Association. Today's webinar is possible with support from BMS Pfizer Alliance. I'd like to begin by going over a few items so you know how to participate in today's event. If you would like a copy of today's presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the GoToWebinar customer service team using the system requirements link found in your confirmation and reminder emails. At the conclusion of today's presentation, you will receive a link to access today's recording, a completion certificate, and an invitation to complete our feedback survey. We welcome you to submit text questions for our presenters at any time in the questions pane of the control panel. We will collect your questions and address them during the Q&A session at the end of today's presentation. It is my pleasure to introduce our speaker today, Dr. Miguel Leal. Dr. Miguel Leal is an associate professor in the Division of Cardiovascular Medicine within the University of Wisconsin Department of Medicine. His passion for medical education and mentorship led him to serve as program director of both the Cardiovascular Disease Fellowship Program and the Clinical Cardiac Electrophysiology Fellowship Program from 2016 to 2021. He currently serves as a member of the American Heart Association Council on Clinical Cardiology, Electrocardiography, and Arrhythmias Committee, and has contributed as co-author of several clinical practice guidelines issued by the American Heart Association, the American College of Cardiology, and the American Rhythm Society, or the Heart Rhythm Society, sorry. Dr. Leal, the floor is yours.
Well, Mr. Namali, that was a really warm introduction, and I really appreciate you inviting me to be here, as well as American Heart Association, in this very important initiative, which is to cover certain important topics within this mega topic that we call atrial fibrillation, one of the most common and the most pervasive arrhythmias that can affect men and women worldwide. And I really like this template, this way to sort of create an easy to remember mnemonic with the 4 F's. So we had fear of bleeding, we had falls, we had frailty. And today I have the honor and the privilege to start the discussion, hopefully a productive conversation on the 4th letter F, which stands for forgetfulness. Essentially appreciating that atrial fibrillation, in addition to the intrinsic damage that it can cause to the heart, it can also be significantly concerning for many other organs and systems in our body, such as, for instance, the central nervous system, such as our brains, given that it has an intrinsic ability to make patients more prone to cardiovascular, cerebrovascular, and embolic events. So we start today's presentation, this is just stating no disclaimers for today, stating something that we all know since we were first trained in medical school, PA school, NP school, and so on, which is that atrial fibrillation is the most common disorder of cardiac rhythm. And it's characterized by a irregularly irregular supraventricular tachycardia. So the atria, the top chambers of the heart, are just beating chaotically without any form or control. On the EKG, when we try to document AFib, we see those fine oscillations of the baseline and no organized atrial activity. And the atria are going so fast that it's estimated that in the average human heart, the atria can beat as fast as 400 to 600 times per minute. And when that happens, as you can imagine, there is no effective contraction. It's just quivering, fibrillation, as the name suggests. And that means that leads to a significant number of consequences, which have to do with the stagnation of the blood into the cardiac chamber. So instead of having this organized, coordinated distribution of heart rhythm impulses, which should be born and raised in the sinus node, right, where the superior vena cava and the right atrium meet together, and then spread in an organized fashion through interatrial fibers into the AV node, His bundle, and Purkinje fibers. In AFib, rather, you have this chaotic distribution of electrical activity, which essentially causes a complete loss of atrioventricular synchrony. This is a slide that I like to show anytime I give an AFib talk, because this disease is not new at all, but interestingly, it has been recognized as such for at least 2 or 3 millennia. And this is, to my knowledge, the oldest description of a cardiac arrhythmia. Now, you can read it yourself and figure out, could this have been AFib or not? But basically, one of the emperor's physicians back in the day in China, way back in the day, mentioned and wrote for posterity that when the pulse is regular and tremulous, and the beats occur after long intervals, which probably is what we'd call bradycardia, the impulse of life is small. But when the pulse is slender, smaller than feeble, but is still perceptible, thin like a silk thread, and the beats are fast and irregular, then the impulse of life fades. And we can all imagine this is a patient with AFib or tachybrady syndrome, potentially suffering from near syncope or syncope. This is an important slide that, again, is probably very familiar to most of us today, just to illustrate that AFib changes its character throughout the timeline. So AFib starts as a paroxysmal disease that typically needs a trigger or initiating factor, things such as a thyroid storm, alcohol intake, a poorly slept night, significant amount of physical or emotional stress, cardiac surgery, and so on. But as time goes by, as AFib is allowed to exist, and if medical interventions are not enacted to try and abort its natural course, AFib can evolve to a more persistent disease, and sometimes even permanent, or as we call it nowadays, long-standing persistent. And that's a disease that depends more on the substrate itself, on the fibrosis and the scarring that takes place in the atria, which become both mechanically and electrically remodeled. And the problem with that is it is much harder to reverse AFib back into normal sinus rhythm once you cross that bridge. It is not impossible, but the likelihood of success is significantly lower. That is why one of our commissions as clinicians who treat patients with AFib is trying to identify them along this timeline. And sometimes a patient will come to us early into the disease course, and sometimes they will come after 3 or 5 or 10 years of disease. And as we all can imagine, the treatment strategies will be very different depending on what modality or type of AFib we are dealing with. Now, it is a disease that tends to affect older individuals, and as our population grows in age, we're going to see more and more AFib, to the extent that you see here. It's estimated that by 2050, the lifetime risk of atrial fibrillation could be as high as 25%, which means 1 in 4 people will have a chance of developing AFib in any kind of form, paroxysmal, persistent, or long-standing persistent. Now, there are younger folks who will develop AFib, and sometimes that AFib has to do with genetical factors. That is a familial form of atrial fibrillation, and there are other possible characteristics of the patient who may have a different type of cardiomyopathy or congenital heart disease that may make them more prone to atrial tachyarrhythmias, which include atrial tachycardia, atrial flutter, and atrial fibrillation, which is our main topic today. And it's important to appreciate when you talk about millions of people, we are somewhere around here. That means that we know for a fact that about 3.5 million adults in the United States have atrial fibrillation. But we also know that this is the tip of a probably larger iceberg, because a lot of this disease is subclinical. In other words, it is present, but is not symptomatic or not fully manifest to the patient or to their clinicians. And it is also known that AFib's prevalence increases as the cardiac function goes down. So it's more likely that a patient will have AFib if he or she has an ejection fraction of 30 or 40% compared to somebody with a normal systolic and diastolic function for that matter. In addition, AFib itself can cause cardiomyopathy. We all know that tachycardia-induced cardiomyopathy is a real entity, well recognized. And up to 10% of patients who are de novo diagnosed may present with a cardiomyopathy. I've had patients that were in dire straits and essentially almost being considered for cardiac transplantation. And then once you're able to hopefully reverse the course of the cardiomyopathy, because you catch them early enough before the ventricle is fully remodeled, you're able to recover some or sometimes all of that systolic function by eliminating the AFib, or at least eliminating the tachycardia component of the AFib. And it is a disease that clearly is associated with increased morbidity and increased mortality. Now, today's topic is forgetfulness. And every time we think about forgetfulness, we think about the biggest fear of atrial fibrillation, which is cerebrovascular embolic events, because they can cause anything from a fatal stroke, a disabling, devastating stroke, to multiple embolization phenomena that over time will lead to a progressive decline in the patient's cognitive function. He or she will be a patient whose ability to remember long and short-term events, or to focus or to concentrate, begins to go down. And we know that many of those patients either blame it on aging, or sometimes their family members will sort of rationalize around the fact that they're getting to their 60s and 70s and 80s, and this is part of the natural course of a human being on Earth. And we know that this is definitely not true for most of us. And when you see somebody have a progressive decline in cognitive function, one of the things that one has to consider is, are we having this as a succession of small vascular phenomena, which could be due to an embolic etiology? In AFib's case specifically, this is an this is an echocardiographic figure. This is a transesophageal echocardiogram for those of us who don't see those tests every day, depicting here the left atrial chamber, and then this little recess, this comma-shaped recess, is the left atrial appendage, which is a structure that by its own anatomy and localization predisposes the formation of clots if the patient loses that vigorous, effective atrial contraction. In other words, if somebody's atrium is no longer able to vigorously propel blood forward, that will be the perfect chemical and physical conditions, if you will, for that stagnation of blood lead to clot formation. And if a clot forms, in this case here, you have this relatively sessile clot, but some of them can be quite pedunculated, and they can evolve from one form to the other as time goes by. Imagine how devastating it would be to have this clot embolized to the brain. I mean, if you look at this here, each of these markers here is 1 centimeter. So this is a very large clot. This is not small. This is approximately ½ an inch in diameter. And this is a clot that could occlude a major artery, either in the anterior or the posterior cerebral circulation. If this clot goes to other organs and systems, it can cause damage elsewhere too. We're focused on the brain today, but this can, as you may imagine, this can embolize into a coronary artery and cause myocardial infarction. This can embolize to a renal artery and cause renal failure. And there is a number of other places in your body, head to toe, where the embolic concerns of atrial fibrillation could be manifested to any given patient. And as we also discussed, the problem is that oftentimes we do not know that these patients have clots. These clots are fully asymptomatic. They form over time. And some people believe that it may take as little as 72 or 96 hours for a clot to form. That is why when we have a patient on anticoagulation therapy for atrial fibrillation, we don't like to interrupt that anticoagulation for longer than strictly necessary, say for a major surgical procedure, for instance, because those drug holidays, if you will, can predispose the patient to clot formation and then potential thromboembolic events that would follow. This is a three-dimensional image of the very same type of diagnostic study, the transesophageal echocardiogram. Again, this is the left atrial chamber here, and this is three-dimensionally rendered, so it takes a little bit of getting used to looking at it that way. But you can see here that same comma-shaped structure on a different patient. And instead of having a more sessile, broad-based clot, this patient has a more pedunculated, protruding clot. Notice, not coincidentally, it is also formed in the vicinity of the left atrial appendage, because this is an area in the heart where even in normal circumstances under sinus rhythm, you have lower velocity coefficients and you have a little bit more stagnation. It's like a pouch, a cul-de-sac within the heart. And if you go into AFib and you lose the atrial contraction altogether, and all you have is that quivering, the fibrillatory action on the cardiac muscle, then a clot is very likely to form in this area, a clot or more. So AFib increases the risk of stroke by 5-fold. So this is not a small increment. We're not talking about a vestigial increase. This is a significant 5-fold increase. And unlike what you would imagine intuitively, this increase has been proven to be similar for any modality of disease. When we first learned this in medical school and nursing school, one of the things that intuitively we think about is that if somebody is in AFib all the time, the risk of a stroke is higher. But time and again, studies show that that is not true, that the probability of a thromboembolic event because of atrial fibrillation is equally concerning in all three forms that we discussed before of the disease. Now, we also know that because these clots are not small, and I just showed you some echocardiographic images of clots as big or large as ½ an inch in diameter, these clots will occlude large arteries. So they are usually associated with more severe strokes than other forms of stroke, such as, for instance, from hypertensive heart disease, or from small vessel disease, or from infiltrative disorders. It is clear that the strokes from AFib have a very high morbidity. They do place patients in nursing homes sometimes and incapacitate some of their activities of daily living or their ability to do those activities. So there is a very high risk of morbidity, mortality, and a poor functional outcome. We all know that many of our patients fear a disabling stroke, sometimes even more than they fear their own death. So again, this is a topic with significant consequences. That is why this webinar today is dedicated to it. So what can we do? what can be done to mitigate the risk of a stroke? Well, in 2001, so an amazing 2 decades ago already, because time really flies, we had the first very important and useful tool that became available to clinicians worldwide to try and do a good job at predicting the risk for a stroke. That's the CHADS-2 score. And the idea is that if that score goes up from 0 to, say, 6, the probability of a stroke would go up in a manner that you would have a sort of a cause-effect relationship or a dose effect. The more risk factors you identified for your patient, the higher the risk and the more aggressive you needed to be preventing that stroke, either as primary prevention, in other words, preventing a first stroke, or secondary and tertiary prevention if the patient had already been unfortunately affected by a cerebral thromboembolic event. Now, a few years later, this is now 2010, the CHADS-VASc score came up, sophisticating, refining the original CHADS score. Now we added other features and we gave different weights to certain features that appear to be more relevant. So I know that most of us are incredibly well familiarized with this from daily clinical practice, but it's important to mention that congestive heart failure or left ventricular dysfunction receives a point. So does hypertension, diabetes, vascular disease, and that includes coronary artery disease, peripheral arterial disease, aortic plaques, and so on. Age between 65 and 74, and female sex. And then 2 features receive 2 points, given their significant higher added morbidity or risk, which are age over or equal to 75 years of age, and stroke, or previous thromboembolic events, previous TIA, and also a thromboembolic disease that may occur outside of the brain as well. Now you might say, why female sex gives an extra point? It's somewhat of a controversial topic, but that is a true fact, a true observation that strokes are a little more disabling when it comes to scores that assess quality of life for women than they are for men. And it may have to do with the size of the arteries in the brain and how big or small a clot needs to be to cause a significant effect. But the bottom line is that women have been significantly affected by atrial fibrillation-related strokes with very significantly high indices of disability and functional impairment. That is why the authors that came up with the CHADS-VASc score realized that female sex for patients 65 and older should receive an extra point. Now, as you see, we have a little more finesse, a little more discriminatory ability in a manner to verify which patients are at high risk of stroke. And when you look at numbers, this is a table that I think is worth sharing with our patients. If a patient with atrial fibrillation, and again, be it paroxysmal, persistent, or permanent, also known as long-standing persistent, if their CHADS-VASc score is 0, the likelihood of them having a stroke on any given year is low enough that a blood thinner, that an anticoagulant could potentially cause more harm than good. That is why those patients do not have indication for anticoagulation. The only exception to the rule, I should say, is if a patient has a different indication for anticoagulation. So for instance, if they have a prosthetic heart valve, or if they happen to have the comorbidity of hypertrophic cardiomyopathy, which has a skyrocketing high probability of causing stroke if the patient has concomitant AFib and hypertrophic cardiomyopathy. But if you exclude those special populations, if the CHADS-VASc score is 0, they do not need anticoagulation. If it is 2 or greater, the risk of a cerebrovascular embolic event is high enough that these patients have the formal indication, the class 1 indication for systemic anticoagulation therapy and lifelong therapy, I should say, in the vast majority of cases. The CHADS-VASc score of 1 remains, to date, a point of relative equipoise. The risk of an embolic event is about 1.3% a year, and we know that for most anticoagulant therapies available today, the risk of having a significant bleeding event over the course of a given year in therapy is about 1%, perhaps a little less. So there is a bit of an equipoise factor there, and that is why the guidelines still recommend that for a CHADS-VASc score of 1, you need a very significant conversation and a very clear shared decision-making process between the patient and his or her clinician to make a decision if they would go or not go with systemic anticoagulation therapy. What we do know is that aspirin has no role anymore. And I say anymore because in the remote years, in the 80s and 90s and early 2000s, we thought that aspirin would be a compromise for patients with perhaps a CHADS-VASc of 1, but we now know that aspirin, unfortunately, in this population would only add harm and potentially little to no benefit because aspirin is an antiplatelet agent. It's typically better indicated in atheroembolic scenarios, not in thromboembolic scenarios, which is the quintessential pathology of atrial fibrillation. Now, luckily for us and our patients, after about 5.5 decades of warfarin, of the vitamin K antagonist warfarin as our only safe and effective form of anticoagulation therapy, aiming for that precious INR window, the therapeutic INR window of 2 to 3, and we know how difficult it is to attain that long term for most of our patients. Fortunately, within the past decade, we have seen the advent of new direct thrombin inhibitors or factor Xa inhibitors. And this is the year that they received FDA approval. So they came relatively in tandem, one after the other. And that really has been helpful for our patients. Obviously, they do carry a higher cost than warfarin, but at least they carry several advantages, including the fact that they do not have as many drug-food interactions as warfarin does. So the patient has a little more freedom in selecting his or her diet. And also, there is far less drug-drug interactions here. Warfarin, as we know, can have its therapeutic levels increased or decreased by certain concomitant medications. And when it comes to stroke prevention and also prevention of overt bleeding events, that is critically important as well. So this slide is just to reiterate the message that aspirin no longer has a role in this field, but warfarin still does, although admittedly in the minority of patients now. The most recent data shows that more than half of patients with AFib are on the new direct thrombin inhibitors, again, that have been FDA approved within the past decade or so. And even the older studies, this study is 2 decades old too, but it shows that warfarin itself, despite its difficulties, despite being hard to get those patients in the therapeutic window 2 to 3, these patients fared far better than if they were on no warfarin therapy. Now, we know that the problem with warfarin is that therapeutic window is very narrow. I already alluded to the fact that food and drug interactions are real and relatively common. And you have to monitor these patients. This is a consequence of what we see here. Because of these first 2 bullet points, you can't just rely on a certain dose and send the patient his or her way. You have to monitor those INR levels periodically, either with phlebotomies or finger sticks. But you do have to do that. And it could be once a week or every other week, depending on the patient. For more stable patients, the traditional standard of care used to be about once a month or even every other month. But you still needed the regular monitoring and dose adjustment as indicated. And vitamin K antagonist warfarin has a very slow onset and offset. So bridging was often necessary around procedures, for example. And again, this is to reiterate that that therapeutic window is very tight. With an INR less than 2, you have a false sense of protection to the patient. He or she may be taking warfarin, but the risk of stroke is still there. And when the INR goes above 3, sure, the ischemic risk is very low, but now you have a prohibitively higher bleeding risk, which is something we also do not want for our patients. And we talked about fear of bleeding as one of the factors here in this webinar series. It's important to appreciate that bleeding is not a small issue. Bleeding deserves attention and deserves respect. We know that anticoagulation therapy is a lifesaver therapy, but we also have to be mindful that patients are individuals and their care has to be individualized and tailored to their needs, one of the tenets of today's precision medicine. So that is why scores like the HAS-BLED and the hemorrhage score came up to inform us and our patients how likely that anticoagulation therapy that we are prescribing to prevent a stroke is likely to be safe or not safe, depending on the patient. And one of the unfortunate realities is that many of the risk factors that make patients more prone to bleeding are the same risk factors that we just discussed in the CHADS-2 and the CHADS-2-VASc scores. Now, this is not going to ever preclude necessarily that a patient should never be on anticoagulation, but it leads to better informed decisions at the bedside or at the clinic when those conversations should be taking place. And that's why these scores are important. I have them here in the slide just to illustrate. There are others, but these 2 are amongst the most used, most widely known risk scores for assessment of bleeding risk. And the question would be, could there be a patient for whom the bleeding risk would be so prohibitively high that one would withhold anticoagulation therapy? And the answer is yes. Although in all fairness, those numbers should be small. The scale tends to tip towards benefit versus harm when it comes to anticoagulation therapy for stroke prevention in atrial fibrillation. It's important to appreciate every time that we were humble enough to look at our own practice and see, I have say 1,000 or maybe 1,500 patients receiving warfarin for thromboembolic prevention. How many of those patients are truly receiving adequate therapy? And this is just one study series that looked at that and realized that a lot of those patients were really not receiving the care they needed. First of all, there is, as we know, a significant percentage of undertreated patients. Now, this is from 2014, so the DOACs were not as widely available. The direct oral anticoagulant agents were not as widely available. This has improved significantly with the advent of the DOACs because, as I mentioned before, despite their higher cost, they do have a more convenient profile for patients to use, especially when it comes to the limitations of dietary interactions or restrictions, as well as drug-drug interactions. But when we had warfarin, for instance, not only were 2/3 of certain series of patients off warfarin altogether, even for the third of patients who was on warfarin, a significant proportion was either over or under treated. And you can imagine how easy it is for this to happen if the therapeutic window is so tight between, again, 2 and 3 for the INR, for the normalized ratio. So it is important that we respect the fact that in our own practices, a lot of our patients could potentially be undertreated. This is something that I have discussed with residents and fellows often throughout the years. It's never fruitless to take some time and go over your charts and see if a patient has an indication based on the CHADS-VASc score for anticoagulation therapy. Are they receiving it, first of all? Because it's amazing how many patients will have it interrupted, either because of a fall or a perceived bleeding risk, or it was stopped for dental procedure and never started again. And that gap of quality of care between the theory and the practice we know exists. It's something we can measure in our own individual practices if we have the time and the energy to do it, because certainly there is relevance behind it. And it may lead to hopefully improvement, quality improvement processes to help these patients attain adequate treatment, to prevent forgetfulness, to prevent cognitive impairment, to prevent memory loss, and to prevent other factors, including the ever so feared stroke. This is, again, just repeating how if you maintain the INR within the therapeutic range, greater than 2/3 of the time, these patients do better. Now, it goes to show how patients on oral anticoagulation therapy, this therapy is forgiving, right? So you don't have to have the patients 100% of the time. Obviously, if we could do that, that would be fantastic. But if patients can have, patients on warfarin, that is, can be between 2 and 3 for their INRs, at least 2/3 of the time, they will do remarkably better than those who don't. And now in the era of DOACs, even this issue should no longer be an issue, because if a patient is compliant to his or her therapy, be it once a day or twice a day, you should have 100% of coverage, except for the occasional drug holidays that a patient will be exposed to. And this is just data from Aristotle showing a peaks event, how it was able to raise the bar, in this case, lower the bar, because we're talking about the risk, right, or the number, the absolute number of risk. This is a significant 21% relative risk reduction. And even if you look at absolute risk reduction, it's somewhere in the range of 0.5%, and it may seem like a small absolute risk reduction, but that's the number needed to treat of 180 or 200 patients. And think about how many patients you treat that have atrial fibrillation every single year of your practice. So we talked about 3.5 million in the United States alone that we know have the disease. That is why even these relatively small incremental positive responses from the DOACs, when you look at the population standpoint, they make a big difference in the big picture. We have learned, sometimes the hard way, that atrial fibrillation can cause progressive changes, either through macroembolization, which is very clearly clinically overt. Patients arrive in the hospital with a slurred speech, with a facial droop, memory loss that looks too sudden to be physiologic, if you will. And those patients will be diagnosed by brain imaging with a stroke. Or sometimes if you can't find anything, they are labeled as having suffered a TIA, a transient ischemic attack. Well, we now know that even medical procedures that are meant to treat atrial fibrillation can cause similar changes. For instance, when we do atrial fibrillation ablation in the EP lab, typically a procedure that is reserved for patients who are symptomatic and either have LV dysfunction or have failed antiarrhythmic therapy, and it's a procedure that has remarkably improved its safety profile since its inception approximately 2 decades ago. When you look at MRIs of these patients before and after these procedures, there are small changes there, suggesting that even those multiple burns that we deliver in the endocardium of the left atrium, sometimes just the char, just the fact that there is some inflammatory tissue left behind, that will cause these small microemboli. But fortunately, when it comes to AFib ablation procedures, if the procedure is successful, the greater good of having the patient have a lower arrhythmia burden obviously justifies any potential risk from the procedure for most patients, not for all patients, as we know. But if you leave the disease follow its natural course, the atrophy, the volume, the brain loss that is associated with atrial fibrillation is now a known entity. This is not something that we postulate, that we theorize anymore. We have enough epidemiological and demographic information that patients with atrial fibrillation that are either not treated on anticoagulation therapy or that are subtherapeutic for one reason or another, be it compliance, be it inappropriate dosing, be it interruptions of therapy that are too common because of perceived fears of frailty, of falls. And we know that some of those fears are real, but some are not. Some are justifiable, but some may be transient. A patient may be at high risk for falls today, but after a physical therapy program, he or she may be in a better place after he or she now has a walker or a cane. So there are dynamic factors associated with that, some of which have been covered in previous webinars to this one. And it's important to always revisit that question. Basically, the take-home message today would be if a patient has atrial fibrillation in any of its forms, what's their CHA2DS2-VASc score? Do they qualify? Do they merit an anticoagulant lifelong? And if they do, are they on it? And if they are not, can we revisit this? Is there a real reason why that therapy is being withheld? Because the cognitive impairment, the progressive brain function loss that atrial fibrillation will cause by this very complex network of microembolization, hypoperfusion because of cardiac dysfunction, and then oxidative stress because AFib is one of the many inflammatory diseases that we know affect human beings. That is why AFib is so related to rheumatoid arthritis, so related to inflammatory bowel disease. Inflammation is a big trigger for AFib, as it is for many of these other entities as well. And this is just to show that there have been very defined phenotypes or imaging fingerprints, if you will, of atrial fibrillation strokes. And again, big and small. Both the strokes that can be disabling enough that will change a patient's quality of life permanently, or those will lead to those almost subtle, almost imperceptible changes that progressively accumulate over the timeline. And again, this is not an exhaustive slide, but it's just to reiterate something that we're used to seeing since the medical school years, since the nursing school years, and you're learning pathophysiology. It's not a disease that causes a unifactorial consequence here. That is the inflammation that we talked about. There is the cardiac dysfunction and heart failure that atrial fibrillation can cause. And again, this incredibly intrinsic prothrombotic state, which can lead to progressive and oftentimes inapparent brain lesions. If you combine those three, inflammation, low brain perfusion because of cardiac dysfunction, pump failure, and then prothrombotic state with lots and lots of small microembolic events over somebody's lifetime, you will catalyze cognitive decline. You will promote, accelerate the onset of dementia. And in today's day and age, again, now that we know this, we really have this commission to do something about it, to identify these patients ideally earlier, and to intervene and promote secondary and tertiary prevention measures if we arrive a bit too late, or primary prevention measures if we're able to reach the patient before his or her first cerebrovascular event. So again, this is supposed to be a relatively short conversation, and hopefully we'll have some discussion, some interaction as well. But the plan was just to share a few thoughts and ideas about atrial fibrillation from the disease itself, explain how its pathophysiology can lead to forgetfulness, which is the theme of our webinar today. And as important as the recognition of that, the awareness that we can help change that scenario significantly by implementing medical therapies that are well proven by evidence, well developed, and at this point validated by multiple societal clinical practice guidelines. So thank you very much for your attention.
Thank you so much, Dr. Leo, for leading today's webinar. We have received some great questions, and we will try to cover them all. But if we're not able to address all the questions on today's webinar, we'll make sure to have questions answered by our presenter and then send them out to your email. Our first question, Dr. Leo, is patients have been reporting that cardiologists have told them to take apixaban when they feel the AFib. Are there any guidelines or studies to support this as needed dosing?
What an insightful question. This is one of the areas of incredibly present interest. We do not have, as of today, May 2022, the ability to suggest that this is an evidence-based approach yet. it would be very tempting to adopt the so-called pill-in-the-pocket approach, similarly to what we do with antiarrhythmics for AFib, for anticoagulants. There is only two big problems, though, that make me pause when I think about this possibility. One is that a patient will come to you sometimes and say, I guarantee that I can feel my AFib events, doctor. Do not worry. Every time I go in AFib, I know I'm in AFib, so that's when I'm going to pop my anticoagulant, my DOAC, B, whichever it is. And then if I notice the AFib is gone, I stop. The problem is a lot of those very same patients will have AFib and not notice it. And sometimes there is also nocturnal AFib that happens when they're sleeping. So if they're not taking an anticoagulant around the clock all the time, they're going to be underprotected or exposed to the risk of thromboembolism during those multiple opportunities when they have subclinical events. Even for those patients who think they can feel all of their events, it's quite likely there are many events they cannot feel. And again, even if they truly can feel all of their events, they can only do that when they're awake. At night, when they're sleeping, they cannot. So they can have 3 hours of AFib overnight between, say, 1 and 4 a.m., and they wouldn't know it. They went to bed in sinus rhythm, they woke up in sinus rhythm, and those 3 hours could have been enough time for their atrial appendages to harbor a clot. And a day or 2 or 5 or 20 later, they could have a stroke because the patient, again, was not on anticoagulation. So that's my first concern. My second concern is that when the heart comes out of AFib, when the heart is in sinus rhythm, it takes a little while for the heart to regain the ability to have an effective contraction. That's why some of the most dangerous days in the life of a patient with AFib are those first few days after the cardioversion. Because once you shock somebody back into sinus rhythm, yes, they regain electrical AV synchrony. You look at EKG and now you have a P wave followed by a QRS complex as opposed to those fine oscillations or undulations of the baseline. But when you look at the echocardiogram, oftentimes that atrial contraction is not strong yet. It's not vigorous yet, especially if the patient has been in AFib for a long time before the cardioversion. So how long would you take that pill-in-the-pocket approach for? Say you go into AFib and you come out of AFib. Do I take another dose, maybe another 2, maybe another 3? So we have way too much to learn about this strategy before we say it's valid, before we say it can be used. The good news for the person who asked the question is that our studies right now, ongoing, looking into that, looking into, is it reasonable? Is it safe? Is it appropriate to adopt that strategy? In today's day and age, May 2022, I would not endorse that approach. It is not evidence-based. And in my specific practice, I carry those two concerns that I just shared with you. Just to reiterate the fact that a lot of AFib can be nocturnal or subclinical, and the fact that it is unclear after the AFib goes away, either spontaneously or via cardioversion. It is unclear at what point the atria are effectively beating or contracting, propelling blood forward again. So it may lead to lots of windows of vulnerability, of exposure, and you don't know how long. And it may be very different from patient to patient.
Thank you, Dr. Leo. Our next question is, if a patient is on anticoagulation prescription and continues an AFib, do they have the risk of cerebral compromise?
So if they are on anticoagulation, they're bringing the risk of cerebral compromise to levels that are comparable to patients who do not have AFib. That's a very important message that we should tell our patients. So it would be ludicrous to say that the risk eliminates completely or that the risk is completely gone. But studies have shown that if a patient is compliant to his or her form of anticoagulation therapy, be it the good old vitamin K antagonist warfarin, which some patients still love because of low cost and it seems to work well for them, or if the majority of patients with AFib today, they have switched to a DOAC agent, to a direct oral anticoagulant agent, their risk of having a stroke or a cerebral embolic complication from AFib is very comparable to the general population. So it's the best that you and your patient can do in order to prevent those risks. One thing that I would like to mention here, because I just remember that might be relevant to today's discussion, is there are patients who, as we know, cannot be on anticoagulation no matter what. And now you have these left atrial appendage closure devices, such as, for instance, Lariat, Watchman, and there are others. And their goal is to try and seal off that appendage. But the problem is, as you can imagine, is those devices are not perfect. There is occasional leak around them in some patients. And also, the left atrial appendage is responsible for the vast majority of the clots in AFib patients, but it's not all there. There are other areas in the heart that can form clots as well. So that's why left atrial appendage closure devices should only be indicated or considered or discussed in patients that simply cannot be on anticoagulation, either because they have repeated GI bleeding events and they've tried multiple times, after there is a bona fide effort to put them on anticoagulation and it just doesn't work for them. And there are those patients out there. I have them, I'm sure our colleagues have them too. That is why left atrial appendage closure devices have a valid place, but it is still a relatively small place when you look at the big, vast number of patients who has atrial fibrillation.
Thank you. Have you noticed a relationship between COVID-19 infection and diagnosis of AFib?
Very insightful question too, right, in today's day and age. So when I began practicing after the onset of the pandemic, so I've been a physician for about 20 years, and the last 2 of the 20 years, so 10% of my practice has been in the post-COVID era. When you talk about, I'm going to talk about anecdotal experience and also experience from other colleagues and other initiatives that have been part of in terms of publications and consensus guidelines. The answer is yes. The short answer is there is a consequence to the heart from COVID-19 infection. And this consequence has been proven very variable. For instance, there are patients with stable coronary artery disease who develop unstable angina or who become more prone to plaque rupture. And it does make sense because COVID-19, although relatively mild and sometimes asymptomatic in a lot of people, it can cause a brutal amount of inflammation in some patients. We know that we've seen patients with ARDS type picture, with acute respiratory distress syndrome, where their lungs are white out on X-ray, and they're literally committed to ventilation, to mechanical ventilation for a long period of time, for days and days, sometimes weeks. So it is reasonable to postulate those patients will have consequences. And they don't have to be on a ventilator for that. Even people with just a more milder version of COVID-19, but still a version that tells them that they're sick, they have to miss a day or 2 of work besides the quarantine time. The bottom line is they will have a more susceptible phenotype to the development of atrial fibrillation. So in other words, you can have a patient who didn't have AFib or didn't know that he or she had AFib, who now has the diagnosis, formally documented and proven. Or you can have a patient who already had some AFib that maybe affected them 2 or 3 times a month, and it's now happening almost every single day. Or episodes that used to last for 8 to 10 minutes and go away on their own, now they're lasting for a few hours, and 2 of them even required cardioversion within the past month, for example. So we do see this increase in the frequency, in the severity, and the duration of AFib-related symptoms in patients with recent COVID-19 infection. What I was saying at the beginning of this answer is that when I started seeing those patients in April, May, June of 2020, we were careful not to immediately attach that label because it could be just a temporal coincidence. But now we've had enough time lapse, and I've had the opportunity to care for enough patients that are recovering from COVID-19 that I think that this anecdotal evidence of mine is more than just an anecdote. And now we're seeing papers from larger physician groups across the country and the rest of the world, not just in the United States, stating similar narratives that the inflammation from COVID has predisposed some patients to more significant AFib. And I'll repeat, it can be either of those 3 factors. It can be an increased severity in how they feel their symptoms, an increased frequency in how often they happen, or increased duration. How long do they last when they do happen? And that's why we have needed to be more aggressive with AFib management for those patients, because the impairment of their quality of life is clearly more significant than appeared to be before COVID.
Thank you, Dr. Leal. Just a couple more questions. Do you use any formal testing or scales to assess potential for forgetfulness?
Potential for what, Amor? I'm sorry?
For forgetfulness?
Oh, excellent question. So the answer is yes. Ideally, when you receive an AFib patient in your clinic, and it does not matter if you are an electrophysiologist like myself, or a general cardiologist, or a primary care physician, or a family practitioner, or a neurologist, regardless of your specialty, you want to have a baseline intake or assessment of that patient, and you want to revisit those questions every so often. In some practices, it could be as early as every 6 months. Most people do it every year or every 2 years even. But what we do is we try to assess through routine questionnaires, clinical questionnaires, if that patient has noticed any consequences of AFib in other areas that are not necessarily cardiovascular. And that includes memory, that includes functional capacity. We always screen those patients, or nearly always, for sleep apnea. That's another big concomitant condition that is often present and many times under-recognized. We tend to think sleep apnea patients, they have to have relatively large and wide necks and a certain body habitus, but nowadays, you know, that is absolutely not true. Any person of any height, weight, sex, age can have sleep apnea, central, obstructive, or both, or mixed. And we know that sleep apnea and AFib tend to walk hand in hand, just like sleep apnea and hypertension, and just like hypertension and AFib. So it becomes this mesh of concomitant comorbidities. And unless you treat them all, it's going to be hard to treat each one of them. So yes, I think this multidisciplinary intake form that tries to look at a patient holistically, head to toe, as opposed to just focusing on the EKG and the antiarrhythmic therapy of the day, I think it's very productive. And I've been obviously very fortunate working in a university. You do have access to tertiary care in essentially every single specialty you can think of. But if you are in a more rural setting, or if you are in a more primary care setting, and this is something that would go above and beyond what the daily busy routine of your office allows you to do, it's something that you can creatively come up with, either a questionnaire to be sent to the patient before the clinic visit, or something the patient can quickly fill out, and you can just lay your eyes and see if there is any red flag or yellow flag that makes you wonder if this patient is already suffering consequences of AFib in his or her brain function, because it is a real phenomenon. It's not just a speculation anymore.
And our last question, a senator candidate in Pennsylvania just had a stroke from AFib. They placed a pacemaker. What is the role of a pacemaker in AFib management?
Great question. So one of the worst things about AFib is that sometimes it gives us no room to treat it. And why is that? Sometimes AFib alternates itself between very fast rhythms, and then when AFib goes away, the rhythm the patient should have, the underlying normal rhythm, is just not as normal anymore because the sinus node has suffered progressive dysfunction, fibrosis. So the bottom line is the patient is now left in this very dangerous place where his or her heartbeats are either too fast or too slow. Well, it just so happens that it is easy, or relatively easy, to treat fast heart rates with negative chronotropic agents, medications like beta blockers, calcium channel blockers like diltiazem and verapamil, and in very extreme cases, which we almost never use anymore, digoxin. Those medications, either isolated or in combination, can slow people's hearts down, preventing or minimizing the risk of a tachycardia-induced cardiomyopathy. But the problem is there is no reliable medication to raise the heart rate up. So sometimes you have a patient who is very fast in AFib and you give him a beta blocker, or a beta blocker combined with a calcium channel blocker, and then it slows them down so much that now they're really dangerously bradycardic. Now they're at the risk of passing out, crashing a car, falling repeatedly. And the only reliable way that we have, and this has been the case for the last 4, 5, 6 decades, to fix slow heart rates is by a pacemaker. Now, pacemakers have evolved. Now you have so many types. You have physiologic pacing, leadless pacemakers. You have synchronization therapy, or the so-called biventricular pacemakers. But the bottom line is, one certain form of pacemaker therapy might be indicated in some patients, but not all patients. It's important to appreciate that unless the patient has this tachybrady phenotype, where he or she oscillates between very tachycardic and very bradycardic rates, you might be able to get away treating a patient without having to ever give him or her a pacemaker. But there are many scenarios where you will need to do that, and that's the role. That's mostly what a pacemaker will do. Because now when you have a pacemaker in place, you know that the patient's heart rate is never going to dip below whatever you set as the base pacing rate. So now you have all the freedom in the world, blood pressure allowing, to give beta blockers and more beta blockers and more beta blockers and maybe calcium channel blockers, and then get the heart rate down where it belongs. A lot of people ask, where does it belong? We know now that it should be ideally less than 110 beats per minute, less than 90 or 80 if you can make it, but at least, even if you're more lenient, less than 110 beats per minute. Otherwise, the heart would be at risk of developing the tachycardia-induced cardiomyopathy that we discussed earlier this hour. But that's what a pacemaker will do to you or to a patient. It allows you to have the peace of mind to use negative chronotropic therapies to slow down the heart, knowing that you'll never overshoot. You'll never slow the patient down too much, because the pacemaker will not let it happen below a certain threshold. And you will set the threshold. To some patients it's 60, others it's 50, others it's 75. It's a very individualized programming as well.
Thank you for the great questions. If we did not get to your question, we will have the questions answered by Dr. Leal and send them out to your email. Thank you, Dr. Leal, for leading today's webinar, and thank you for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey on the presentation. We would appreciate if you would complete that and provide your feedback. In that email, you will also receive a link to view a recording of today's presentation and a certificate of completion. On behalf of the American Heart Association, thank you for joining us and have a great day. This concludes today's presentation.
Thank you.